Welcome to another episode of Inside Medical Malpractice. I am so glad you're here today because we have a fascinating and amazing guest. Someone that I think many of you will have heard of or read about, but only in the news and maybe not yet in person. Registered Nurse RaDonda Vaught from Tennessee. On March 25, 2022, a jury found RaDonda guilty of criminally negligent homicide for her part in a case that involved a fatal medication error. A criminal prosecution for an unintentional medication error is rare, but it happened, and RaDonda is here today to tell us her story. There's a reality that all healthcare providers somehow learn to shoulder, but never ever forget. And it's that a single moment of inattention, a lapse in judgment, a split second of forgetfulness can mean the difference between a life and a death. Any of us who work in the busy, exhausting, messy imperfection of our modern healthcare system knows exactly what I'm talking about. The episode today is a continuation in the podcast series on the most problematic malpractice issues in healthcare, and this is the second episode that we've done on medication errors. We first tackled this messy subject in October of 2022 with Toronto lawyer Paul Cahill. If you haven't heard it, go back and take the time to listen to it. That episode quickly zoomed to one of the top 5 downloads of all times and still sits right there today. In that episode, we told the story of medication errors from the perspective of a malpractice lawyer, as Paul shared multiple real cases from his own practice. But today, we're going to tell a story about a medication error from the perspective of a nurse whose error is the one that every healthcare provider fears. In the first podcast on this subject, I mentioned that at conferences across North America, I had asked thousands, and I mean thousands of nurses, of practicing nurses, who in the room has never made a medication error. There wasn't one. There wasn't one anywhere. I hardly even know of a human being who hasn't made some kind of a medication error. I mean, who hasn't missed a dose of antibiotics or forgotten to take a morning medication and put the drops in their eyes on the last day they were supposed to? But luckily, in many cases, medication errors don't cause harm, even in healthcare. For instance, if a nurse accidentally administers Tylenol instead of aspirin, as long as the patient doesn't have a bad reaction to whatever it is they got, it's very clearly a medication error, but all turns out well. It will likely never be reported, and the issues surrounding how and why it happened will never, ever be examined or fixed. It's no doubt that this lack of negative consequences results in many errors and near misses never being looked at, never being talked about, so nobody is ever really sure how pervasive this problem is, but it's pervasive. As I said at the beginning, criminal prosecution for an unintentional medication error is an extraordinary event. And the key word in that sentence is the word unintentional. When a nurse kills intentionally, the system expects and demands criminal prosecution. In Canada, you may have heard in 2017 of Ontario nurse Elizabeth Wetlaufer, who was sentenced to life in prison. She was one of the most prolific serial killers in Canadian history. She murdered 8 elderly patients and attempted to harm 6 more with insulin overdoses between the years 2007 and 2016. And more recently, a neonatal nurse named Lucy Letby killed 7 babies in her care and tried to kill 6 others in a hospital in northern England. She has since also been sentenced to life in prison. But this is nothing like that. The story we're going to talk about today is not that story. No one ever has argued that RaDonda intentionally set out to cause any harm. Her case gathered national attention and sparked debate over when or if it's ever appropriate to prosecute healthcare professionals for medical errors. The American Bar Association issued a statement saying, "A robust culture of safety relies on self-reporting and transparency to drive process improvement, and criminalizing errors instead foments blame and creates fear." The Institute for Safe Medication Practices called the decision disturbing and unjust. It alleged that the decision reflected significant outcome bias and an inability to differentiate between human error, at-risk behavior, and reckless behavior. The American Nurses Association had this to say: "We are deeply distressed by this verdict and the harmful ramifications of criminalizing the honest reporting of mistakes. Healthcare delivery is a highly complex state. It is inevitable that mistakes will happen and that systems will fail. It is completely unrealistic to think otherwise. The criminalization of medical errors is unnerving, and this verdict sets into motion a dangerous precedent. There are more effective and just mechanisms to examine errors, establish system improvements, and take corrective action. The non-intentional acts of individual nurses like RaDonda Vaught should not be criminalized to ensure patient safety. This ruling will have a long-lasting negative effect on the profession." And I think RaDonda is going to speak to that today. What's interesting is a public version of stories in healthcare often celebrates the hero who made the save or quickly villainizes the individual who caused the harm. They rarely acknowledge the systems, the people, the events, and the backstories who contributed to the outcome, whether it was a good outcome or a bad outcome. When things go wrong, it's so much easier to tell a story about a bad doctor or a bad nurse than to talk about a flawed system. But the bad nurse, bad doctor story is never the whole story. So today we're going to hear from RaDonda Vaught. We're going to hear her story. We're going to hear her struggles, her learnings, the multiple ways the last 5 years has changed her life. And perhaps most surprising of all to me was the unexpected gifts and kindnesses this experience has brought her way. Welcome, RaDonda, and thank you so much for being here today.
Thank you, Chris. I appreciate you having me. I know this has been a little bit in the works that we've been trying to get together, so I'm glad that it finally got to happen.
Yeah, me too. Me too. And thanks so much for taking the time. I know you're a farmer now and it's summertime. And the first time we talked to you were on your way to some kind of a turkey market, and I was working at a farmer's market. I was working at a farmer's market selling honey. So I know it's been busy, and I just so appreciate the time.
You know, this has been the busiest year that we have, summer-wise, that we have had to date on the farm. Each year we gradually increase things a little bit, try to find that balance and scale up when and where it's appropriate. And this year, a lot of things happening at once. So yeah, very busy, very, very busy.
Good. Even better reason to thank you for your time. I appreciate it.
Oh, thank you.
So we have so much to talk about today, and I think the whole audience, and not just healthcare, I think healthcare, the legal world, the public has so much to learn from your experience. So everyone listening, just buckle up and sit tight and don't go anywhere, and let's hear what RaDonda has to say. I just want to start by asking you a very general question, and that is just tell us the story. For those people who haven't heard us, just tell us the story from your perspective.
I mean, it's a long one. You know, there hasn't been a single interview with an investigator or anyone that has lasted under an hour and a half to 2 hours.
Mm-hmm.
So I'll try to simplify that a little bit, because I think we'll get into some of those with questions. But can I first say, you referred to this as my story, but this isn't just my story. This story is much bigger than just me. And I only have this story because someone lost their life. So it's not just my story. It's Miss Murphy's story. It's her family's story. It's everyone who was involved there, you know, with this. It's not just me and my story. There were a lot of other people that experienced this. You know, my name and face is just the one that's most associated with it.
Well, thank you for that. I appreciate that you brought that up right in early. Thank you. Thank you for pointing that out.
It's just something that I've tried to be really cognizant of. And, you know, I just want to make sure that anytime I'm talking about this or someone's asking me about it, you know, that we remember this is an opportunity for me to talk about something that's very important, but it come at a price, and the price was someone's life. And so I always want to remember, people to remember that, we don't just want to talk about how we improve healthcare for the sake of nurses or, pharmacists or doctors or whatever. It's always about the patient. That's why we come to do what we do, whatever our scope of practice or our role is. It's for the people that we're caring for. So Miss Murphey plays an equally big, if not bigger, part in this story. So just for her, always keeping her family and loved ones in this story.
Thank you. And that's from all of us. I'm sure all of us listening in, we all feel that. So thank you very much for bringing it up.
Every nurse I've talked to, they understand, this went so public, and I think it was hard for Miss Murphy's family to absorb all of this support, that was being publicly displayed for me by nurses saying, this is wrong, this is wrong, this is wrong. I do think they understand the reason behind the support, but at the same time, it can almost seem somewhat insensitive to a really grave loss that they've experienced. And so, it's, just something I'm always sensitive about. But to tell this story of Miss Murphy and I was working at Vanderbilt in Nashville. This was December of 2017. It was the day after Christmas. It was my third shift in a row. And I was working as the help all nurse, which is essentially a resource nurse for our unit. I was in my home unit, which is the neurosurgical ICU. We took care of stroke patients, neurosurgical patients, just a wide variety of neurodiagnoses. And on this particular day, I also had a new hire nurse orientee with me. He was maybe 3 weeks in to his licensure phase. He'd worked with us on the unit for a few months prior as like a patient care tech to kind of familiarize himself with it. And he was going to be part of our nurse residency program. He had just graduated from a college in Ohio. So it was coming from out of state. So it took a few months for that. So he had some time to be familiar with the unit, and he actually chose me as the person to be his primary preceptor, which I was kind of honored by that. I felt privileged to have the chance to share what limited information I knew to this new group of people. So we were going about our day. Shortly after lunch, maybe sometime in the 2 o'clock hour, 2:30-ish, we were working on going to see a patient in the emergency department who required a swallow study. And this wasn't going to be an ICU or critical care level patient, but the nurses in the emergency department were not as familiar with swallow screens on stroke patients as the people in the neuro ICU were. And we'd had several over time that had failed or should have failed but passed, and then later wound up having issues with aspiration pneumonia, et cetera. And so part of this help all role over the last month or so had become to include taking patients downstairs in the emergency department, doing those swallow studies. This was also a skill that my orientee needed to practice and evaluate and learn. So I was talking with him about why we do these studies for the patients in the ER and the importance of it, going over his checklist. And I get this call from Ethan asking me to go downstairs and give a medication to his patient who is in the PET scan area. We had a discussion about what she needed and where she was located, about her being off the unit unmonitored, and what kind of drugs she needed. So I went and gathered the supplies that I would need from an empty room. I looked in the Pyxis system for the drug under her name, and it wasn't there. So I called Ethan back to confirm that he had actually received an order. Was it a doctor written order? Was it a verbal order that he'd entered? And he confirms, yes, it is there. I went back into the empty room, pulled up her MAR on a computer, confirmed that it was there, and I wrote the drug information on the lab bag with a Sharpie. And then I went back again to the Pyxis. Still wasn't there. At this point, that didn't alarm me because this was something we'd been working through over the last probably month and a half to 2 months since we launched Epic in first or second week of November, I think, of that year. And we'd been dealing with all of the challenges that come with implementing a brand new EMR system throughout, one of the biggest hospitals in the state, let alone clinics, the emergency department, the OR. This encompassed every area. This was a huge change for us because we'd gone from this proprietary system of Star Browser that Vanderbilt owned and developed. And then on top of that, this was a brand new version of Epic that had just launched in 2017 and got together with Star Browser and had a baby, and they called it eStar. So you had a lot of things going on there, a lot of technology, a lot of code, a lot of working parts that largely worked well, but there were still some challenges that we were all figuring out. One of those challenges were delays in drug orders crossing over to our Pyxis. So there would be things that had been ordered, the doctor had ordered it, the nurse had acknowledged it, pharmacy had approved it, yet it still wasn't there in our Pyxis for us to retrieve for the patient. And they'd gone through series of, upgrades and updates, et cetera, but this was still something we were experiencing. So overriding drugs was much more common during that time than it had been previously. Although I will say the basic practice to retrieve a bag of IV fluids was to override. In order to access the medication refrigerator, you had to override to get the key, and then override to access the fridge, and then override again to return the key. So even outside of the issues with communication, the override itself was built into our daily practice. It was something that we all did just as a routine, and that was the standard. It wasn't a workaround. That was the way the system was set up. So this egregious idea that overriding was something that was just unheard of, it's not the case. I believe out of the roughly 100 drugs on Miss Murphy's profile, something like 20 of them were obtained using the override function in some form or another. So anyway, here I am. I'm back at this Pyxis machine. It is 2:59 and 49 seconds, and that's very important. Again, I can't find this drug. It's not profiled. It's not stat. It's not PRN. And the only other option is override. So I selected that. I typed in Versed. A drug came up, and I selected the first one. I made 2 mistakes there. The first, not looking to ensure that I was grabbing the correct drug, because I was talking to my orientee, which I should not have been. And the second was there were 2 options at the bottom to switch between brand name and generic name of drugs. So me looking for Versed, midazolam would have been the only thing that would have populated under that generic category. So I retrieved this drug. There's no stop warning on the Pyxis screen that says, typically you see something like, this is a paralytic agent, physician must be present, you must be ready with intubation materials, et cetera. It requires ventilation, nothing like that. There were also typically a second person would either have to scan their fingerprint or put their password in to allow you to retrieve a drug like that. Neither of those things happened. There was a stop warning, like a standard sized sticker stop label on the drawer, the lid of the drawer, which is also on heparin, insulin, steroids, and a number of other things that we utilized every day. So the warnings that were there were not substantial, and they didn't alarm me or alert me to any difference. I did notice that it was a powder form, and in my mind, I wrote that off as being part of another issue that we were dealing with since earlier in the fall, which was a hurricane that happened in Puerto Rico. I want to say sometime maybe September, October timeframe. A lot of drugs are manufactured there. A lot of the drugs that we utilized were changing constantly, and we were well aware of this. So we were reconstituting a lot of things that we would have normally reconstituted, either mixing them in small vials or putting them on 50 or 100 ml bags to reconstitute and then hang. But drugs were coming in different forms quite often. You might even open a cabinet and a drawer and see two very different looking drugs, maybe a different brand, etc. The same thing, but looked very different. And so it was not uncommon for us to see different things. Again, it should have been a warning, but because of those circumstances, it didn't alert me as something that should have been different. I grabbed, all the other things I had. I put everything in this bag. My orientee and I went downstairs. We were looking for PET scan. I'd never been there. I didn't know anything about that particular department. And I remember having asked Ethan the second time again, this patient doesn't need to be monitored. They're okay being off the floor without a nurse. Do I need to take a travel monitor down there? And he says, no, she doesn't need to be monitored. She has orders to be off the floor. And I saw in her MAR also that she had received Versed sometime in the 24 hours prior, maybe for an MRI. She'd also received Versed. So again, I'm thinking this is something that it must be the drug the physician prefers for her for whatever reason. I go about my business trying to find my way down there. In the meantime, some things are happening that I was unaware of. There was some conversation going on between the technicians, the nuclear med technicians, and the primary nurse regarding that exact thing, which was monitoring her. They had called Ethan. They had also talked to a staff nurse who was in the interventional radiology department for that day. So not just all over, but actually handling whatever procedures were going on about the use of this drug for this patient. There was concern that she would need to be monitored. They again called and talked to the primary nurse, who says, again, no, this patient doesn't need to be monitored. So we're all on different pages about what's happening with this patient. When I finally did arrive down to PET scan, I found Miss Murphey in a corridor between two set of double doors on a bed. And I assumed that was her simply because of the type of bed that she was on. So I approached her, introduced myself, confirmed who she was, checked her armband against a sticker I had taken from her chart, and told her I was there to give her the medication for anxiety. So I looked in some empty rooms for a scanner because barcode scanning was a very big deal. They were really trying to make sure that we were compliant on that. And the barcode scanner knows the difference between a patient's armband and a sticker that you pull out of their chart. It knows that there's a different number there. So actually scanning the patient and the drug at the same time with the scanner was a very big thing. I couldn't find that, and nuclear med tech came out of the opposite doors from which I came. We had a brief conversation about the scanners, and she told me that they didn't, in fact, have any scanners there. So I went ahead and reconstituted the medication. I flushed her IV, which was in, I think she had a left EJ, maybe, was one line. It was saline locked. I flushed it. There was a little bit of burning when I flushed it, which is pretty common when you have a saline locked IV. I flushed slowly. I made sure the burning stopped. I gave her the 1 ml of what I thought was Versed. I flushed again with a 10 ml syringe to follow, and the nuclear med tech was essentially waiting to take her to her scan. As soon as I was done, it was obvious that she was ready to take her somewhere. And I'd also been told by Ethan that she had already received her contrast medium that she needed for this PET scan. And I don't know a lot about that, but I know the time frame was somewhere between 45 minutes and an hour. And I'm sure it had taken me at least, 15 to 20 to get this phone call from Ethan, gather these things, and get down there. So my assumption is the time is ticking. Otherwise, they were going to have to cancel this procedure, which was going to potentially delay her from being able to be discharged. And they were hoping to do that soon because, again, it was Christmas. So all of these things are happening. Additionally, I didn't realize until the trial, but the nuclear med tech believed that the male nurse orientee who was with me was the nurse that she'd been speaking to on the phone. So she was confused about that. She was wondering what I was doing there and why I had also come with this person, why I was giving this medication and not him. So I believe that she was confused. I wasn't aware of it. We were all on very different pages in terms of what was happening. I was under the assumption she was taking her directly into a PET scan and that they were waiting for me to do that. And in fact, what actually happened was the patient went into a room by herself because she'd been giving this radioactive tracer. Her family was actually told that they couldn't stay with her, that they needed to leave to go back upstairs. They weren't allowed to wait with her after she'd received this radioactive tracer. She was supposed to be in a lead-lined room by herself. She was out in a hallway, not in a lead-lined room. They also believed that the medication wasn't going to make it there in time. And so they had set up for a transport agent to come pick this patient back up and take her back to her room. So it was actually the transport agent who found Miss Murphy unresponsive in the lead-lined room waiting for her PET scan. The transport agent showed up to take her back upstairs. And when they found her unresponsive, they alerted the nuclear med tech to that. They called a code. At that point, I was already through the ER. That patient had left for an MRI. So I went back upstairs and made my way back to Miss Murphy's room to talk to Ethan. And I had this bag in my hand, and I was giving it to him outside of her room to let him know, hey, there was no place to scan this drug. Also, the rest of this Versed is going to need to be wasted. I'm going to leave this with you because I don't want to be in and out of 36 rooms with a bag of Versed in my pocket, and also I don't know when this patient's going to be back. So you can keep it safely in a locked cabinet in her room or on your person, and then let me know when she gets back. I'll back chart it. There's a place to annotate that and explain where she was. We can scan it, we can document it, and then we can waste it in the Pyxis. And at this time, the code is being called over this rapid response phone that I'm carrying. It's very loud. It sounds like, when a volunteer fire department individual is in Walmart and you get that loud thing over the radio. That's what it sounds like. It was the Life Flight phone. It's very loud. Any kind of alerts that are going out come over this. The rapid response was called. It only gave a location and a number. It didn't give patient information or any other details, but her family members were standing just outside the room having a conversation with the case manager. They heard the alert for PET scan. They were concerned that their family member was down there. Ethan and I tried to call. There was no answer. After 2 attempts, I let them know I'm going to go get my charge nurse, and we're actually going to walk downstairs and just make sure that this isn't our patient. And I will let you know. So Dania and I proceeded downstairs. When we found the code, it was in fact Miss Murphy. Our critical care doctor for our unit and that team was actually already down there. He'd responded. They had her intubated. They had a pulse. They were going to prepare to move her back upstairs. So at that point, Dania and I assisted with transporting her back upstairs. We placed her in a critical care room, not in the step-down bed that she was previously in. And we spent probably the next 45 minutes to an hour stabilizing her, putting her on the vent, giving her various medications, drawing labs, putting in central lines, all of the things that you would do post-code. And I was leaving the room as things were settling down, and I had maybe a second or a third set of labs that we'd drawn, because we know those values change from immediately post-code to once you're a little more stable. So we drew a final set of labs to see how she was. Hi, guys. And I was taking those to the tube station to send. And that's when Ethan approached me with the bag in hand. He said, is this what you gave the patient? I told him, yes, that's what I gave her. And he said, this isn't Versed. And I said, what is it? He said, it's vecuronium. There really aren't good words to describe. You just know that this was not good. This was a bad situation. So I asked him to give this bag of medication to the charge nurse. And I turned around and walked back into Miss Murphy's room and told the group of doctors and nurse practitioners in the room. They were discussing what could have caused her change in status. Did she have a worsening in her bleed? Was it a cardiac event? Was it a PE? What could have happened? And I let them know, I don't think it was any of those things. I didn't give her the Versed that we talked about. I gave her vecuronium. And I remember Lindsay, a nurse practitioner on our unit who I have an enormous amount of respect for. She knew, she knew exactly what I knew. And she just said, I'm so sorry. We knew that this was the worst possible situation. To say it was unideal. This was not a good situation. At that point, I did excuse myself. I went to my nurse educator's office, who was there that day, and I tried to gather, myself, and I didn't really know what to do. Sorry, that's my cat. He's saying hi. So, I was asking for guidance. What do I do here? I don't know what to do. I don't know what to do. So, I talked on the phone with several people. I spoke to my unit manager, who wasn't in. Again, it was the day after Christmas, not a typical business day. It might have been a weekend. I don't remember, but it was kind of a skeleton crew. So I spoke with my manager, Misty, on the phone. I spoke with someone from risk management, possibly. I spoke with our ACNO, Marcia Lupica, I think is her name. I spoke to a few different people on the phone, and, I was told I needed to fill out this incident report, which is a Veritas report, and just include the details. And the thing that I kept hearing over and over from everyone is, this is a systems error. This is a system error. This is a system problem. I kept hearing that over and over. When things like this happen, it's generally, this is a systemic problem. It's a system problem of some sort. So I went about trying to write this report, include as much detail as I could, linked all of the relevant employees that I could, people that I had notified, etc. And during the course of that, I spoke with risk management, and I remembered, it wasn't till the trial that I remembered this, but I remembered speaking with someone. I just didn't remember which person it was, but I told them I didn't document this. I didn't document this drug. And I explained the process of why I was never at the same place at the same time with the drug, the patient, and a scanner. All three of those things never lined up. And until after I was aware of what it was, for me to have gone back in the room at that point probably wouldn't have been appropriate, but that would have been, again, the only way that myself, the drug, the patient, and the scanner would have been in the same place at the same time to document the administration of this drug. So I told this to several people, but it was actually Diane Moat with Risk Management who told me not to worry about it, that Epic would capture it. In part, that's true. It captures my override and it places it on the MAR as a blank drug, my name and the drug. No dose, no route, nothing, no doctor associated with it, no administration, just an override, that drug, and my name. It doesn't document anything other than that. But her advice was to, I didn't need to worry about that. Epic would capture it. I left that night and I never returned to work. I came back 6 days later for a meeting the day before I was supposed to return to work. And at that meeting, I was terminated. I didn't see it coming. Maybe I should have saw it coming. My manager came down the hallway with one of those big cardboard paper boxes like you see, in movies and on TV with things in it. Didn't realize were my things. And we had a meeting. The ACNO asked me how I was doing. I told her I wasn't doing well. The worst case scenario had already happened. I had learned that Miss Murphey had passed away, that her family had withdrawn care on her because of her poor status. And, at this point, I was scared. I didn't know what to do. I didn't know what was going to happen with my job, with my license. I was afraid that the family was going to come after me for some, sort of responsibility. And her response was, well, I think we can take care of, I think we can address a couple of those things today. Again, should have been a warning, but I didn't pick up on that. Ultimately, she let me know that they were going to let me go because I didn't follow the 5 rights of medication administration. She let me know that my actions were reportable to the Board of Nursing because I'd failed to follow, those guidelines. That the letter to the Board of Nursing was written in a very benign way, her words, which I thought was an odd way of putting it, but I remember very specifically thinking that's an odd way to describe it. She said it's written in a very benign way. It doesn't, discuss any of the severity of the event. And we just want you to know that it's not because of the outcome of the patient that we're letting you go. It's because you failed to follow our policies and you failed to follow the 5 rights of medication administration. She told me that I was never, I wasn't rehirable to work at any Vanderbilt facility ever again. That I was free to continue working as a nurse, just not there. So, and she took the liberty of making an appointment with an employee counselor that she let me know I would have the benefit of using until the end of the month when my benefits, ran out. But that was a resource for me until that time. And she made an appointment for the time frame right after our meeting that she terminated me. My manager did not have a lot to say during the course of this meeting. She was not on the same page as the administration's decision to terminate me. And I think she felt as though there really wasn't a lot for her to say. The decision was far beyond her ability to change. And so that was the decision that was made. She was there as a formality. not necessarily, I think, as a part of the process in agreement with it. So, from there, I was told it was going to be months before I heard from the Board of Nursing. It would be a while, it'd be several months, and that, I could continue to work until then. They would just do their investigation, and, it would be up to them what I would do moving forward. And it was months. It was the end of August of 2018 before I heard anything from the Board of Nursing. And at that point, I had spent 6 months not working. My husband was very supportive and encouraging of me to get back on the horse, essentially. I looked at some really low risk jobs, maybe doing occupational health for employees at Opryland Hotel, maybe working at like a dermatology clinic, checking in ladies who wanted to get their Botox done. Low risk, just as low risk as I could find. And again, he said, "What are you doing? You're better than that. You're better than that, and you have a skill set, and you were very good at this, and you need to go back. You need to go back to doing what you were good at. You can't just sit here and wallow away in this. You got to put yourself back out there. You got to get back on the horse."
Was that a tough 6 months for you?
Oh gosh, it was awful. It was awful. I was definitely not, the best version of myself, or really any version of myself that I had ever seen before. Depression is a real thing. And I don't think that, people don't really understand that until you've just been slapped in the face with the hard reality of it. I was not okay. I never had thoughts of harming myself. But there were a lot of days where I felt like I would be okay if I ceased to exist. Mm-hmm. Both of my grandmothers passed away in the 3 months after Miss Murphey died. And I was there when my second grandmother passed away, my maternal grandmother. And, I just remember thinking that this was an eye for an eye.
RaDonda.
I mean, honestly, this is her. This is my granny. Whenever we got married, she's so tiny. She's such a short little lady.
Oh, she is. She's barely up to your nose.
And I had on just like little tiny kitten heels, and I was standing in dirt.
Bless her heart.
She passed away in March of 2018. And I had always told patients and their families, when they would say, they would acknowledge how caring I was and if they were appreciative of that. And I told them, I take care of people the way I would want my grandmother to be taken care of. And that was a fact. I take care of them the way I would want her to be taken care of. And so it really did feel like I took someone's grandmother away from them, and now that was being taken away from me.
Are you still feeling that?
So life happens, Chris. It happens, and sometimes you can put a lot of thought into how those things add up or why something happens, but you can't change the fact that it did happen. And you just have to accept the reality of what it is. When you start to go down too many rabbit holes, you really find it hard to just move forward with the reality of what is. So I've been trying to keep my head forward and not down or backwards, in terms of that. For a very long time, I absolutely felt that way. Some days I do still feel that way, but It just is, it is the reality of the timing. But it definitely sat with me in I think in a much deeper and darker way than it would have outside of experiencing that situation with Miss Murphy. I think I would have dealt with it a little bit differently. My grandmother's health was not good. And I knew that if she ever went into the hospital, she wasn't going to make it out alive. She would refuse to go to the doctor at all costs. And she smoked 2 packs a day on her oxygen tank. I mean, her health wasn't great. But it was unexpected and it was quick. Often like those things do happen. So, the timing just made it a little bit more difficult to handle. But that happened in the first 3 months of those 6 months. Several people passed away that were close to me. A lot of really tragic things. And it was hard. It was a hard pill to swallow, looking at all of this grief and loss and sadness that was going on with the people around me in my lives and watching them go through these things too. Knowing that I had in fact caused this same grief and pain for someone else. It took some time. Going back to work, it did help.
When did you go back to work and where did you go? Did you go to occupational health or did you go back to neuronursing?
No, actually. So I applied for a neuro ICU unit at Centennial Hospital, which is also in Nashville. It's an HCA, it's part of their TriStar division. And I also applied for a couple of other positions there. And when I went to neuro to interview, I thought, I feel like this is just a little too close to home, maybe. And I knew that I had far more experience than I would ever need in this type of unit. But at the same time, I felt like I needed something that would be challenging. And I was never one to really like that cardiac world. Not that I couldn't do it, but I knew that it would be a significant challenge. And so I interviewed with the CVICU as well, and I wound up choosing that unit to work in. I thought, I liked the manager, I liked the staff, and I thought this will be, I can apply my skills here. I can also learn some new things here, and this will be very good and challenging. And I think that will be healthy for me. And it was. I learned a lot of things while I was working there, experienced a lot of things, met a lot of really great people.
It sounds like you're a great nurse, RaDonda. Were and probably still are, because I'm sure there's some crossover in what you're doing now. Where you?
Oh my gosh, I can't even tell you the amount of times that I have reached back into my nursing brain to pull something out for, taking care of animals on the farm or other people's animals. It's definitely prepared me to be a better care of my animals.
I believe it. I 100% believe it. So listen, when you were interviewing at these new jobs, so we're 6 or 8 or 9 months after this has happened, were they aware of the incident that had happened?
No.
Oh, no. So that was still under investigation.
I still hadn't heard anything from the Board of Nursing. I took this job at the end of May. I think my official hire date was the very last day in May, and I started the first week in June. When I was terminated from Vanderbilt, my manager was very transparent about her feelings. She told me very clearly, she was like, I advocated heavily, I tried to get them to keep you on in some other role, some other capacity, and I didn't win that battle. When you get ready to go back to work, you put me down as a reference. Absolutely. I will absolutely give you a recommendation when you are ready to go back to work. And so, during that 6 months off, my husband and I did a lot of things on the farm. We took that time. And so, I didn't elaborate on the details. I give them Misty's information. I put in my work experience, and I didn't really know, how do you go about saying that?
Yeah, understood.
It was, I didn't really know what to do or what to say there. So I didn't say anything at all about it. The board of nursing hadn't reached out to me. I didn't know what was going to happen, what their conclusion was going to be. So I left it off the table.
I have no doubt that it changed you, though, and weighed heavily on you while you were working, and you were ultra careful from that point on. Is that correct to say that?
Yeah. Yeah. Terrified of making even the slightest mistake. I remember working one evening. I come into work. I worked night shift, and I stayed on night shift. I had no intention of going to days because I just felt like that put me. I could be more comfortable, just with less people around at night. It made me less anxious. So I was happy to stay on nights. I come in one day, and there was a young nurse who, she wasn't a brand new nurse, but she was still quite young, and she was a new hire to the unit. And she'd made a medication error during the day. And she was giving me a report on her patient in tears, trying to finish her charting. And, I asked her about what happened. I asked her what was going on with the patient. Where was the physician, or where was the charge nurse, or was the team caring for her? Was everyone aware? How was the patient doing? Are we still looking for any potential side effects from this? Everything was fine. The patient was fine. The team was aware. It was documented. But she was absolutely beside herself and upset. And I sat down with her and I said, listen, I can empathize with you because I have been there. And I'm telling you that mistakes are inevitable. Take this with you, learn from this moment. It will be invaluable to your career moving forward. You won't ever forget this, but it could have been a lot worse. And I'm here to tell you that I know the reality of that. And I told her briefly, just in a sentence or two, that I had been involved in a medication error with a patient and they did not make it, So I just reminded her of the reality of the situation that she was in. Yes, she'd made this mistake. Yes, she was going to be harsh on herself. Use this as an opportunity to learn. Look back at what you did without holding that pistol to your head or holding that knife to your throat and blaming yourself. Look back at what you did and really evaluate where you were in your practice. What happened? How could you have done something differently? Could you have caught this mistake? If so, how? If not, what could have potentially been put into place to make it different? And I remember her being really grateful to have that conversation. I said, I'm not here to judge you. We're here to take care of patients. And part of that is to be open and honest and transparent. We have to know, because what if something would have happened to this patient later on down the shift and no one knew, that this drug was on board, or it interacted with this other thing, or some delayed effect happened that could have caused harm to the patient. You did all the right things. And now we can sit back and be grateful that nothing terrible happened.
I think that is just a beautiful conversation that you had with her and probably changed her life, because so often I've made mistakes and I've never had anyone talk to me like you just told me you talked to that nurse. It was like, you shouldn't have done that. Fill out this incident report, and for God's sake, don't do that again. But missing the analysis of how and why, what went wrong, and how do you prevent. There was no conversation about that. It was just really simply, don't do that again. And you're scared and you feel terrible. Even when cases, even when the medication error doesn't cause anybody any harm, it's just an error. You just made a mistake. But the teaching around it is not, in my experience, is not even close to that conversation you have with the nurse. So there's nothing like experience to make you a good teacher. I'll say that.
Yeah. I mean, I think you're right about that. There's a reason why people who have gone through very specific and certain experiences don't seek help or counseling for that, because they don't want to talk to someone who doesn't have the experience that they've gone through. People who are addicted to drugs, they don't want to talk to a counselor who has a doctorate degree, who's, only taken aspirin and Lipitor during their life. Veterans of war, they don't want to talk to, especially male veterans of war, which is the highest population. They don't want to talk to some, 28-year-old PhD psychology student who probably has very different viewpoints from them and has no real association with what they've gone through. So, I mean, yeah, the experience does make you a better teacher.
It does. And you and I talked briefly about this last week. I haven't been at the bedside at a hospital for several years now, for 13 or 14 years, and people often ask me if I miss it. And I don't really miss bedside nursing. I worked really hard for 35 years as a labor and delivery nurse. I don't really miss the bedside nursing, but what I miss is nurses. And the exact thing that you just described is I could come home and tell my husband a story about what happened at work, and he might take his eyes off the TV for a minute and give me a quick hug and say, I'm sorry. But there's nothing like telling someone who's been through what you're going through and sharing those moments. So tell me something. Have you, during all this time, had you connected or had any conversations with the family members, Miss Murphy's family members?
I actually did. It was my biggest fear for a long time, leaving the house. I didn't know, where Miss Murphy was from or where her family was from. And it wasn't until the TBI contacted me in December of 2018 after CMS come in to investigate, and things were very public on the news in Nashville about Vanderbilt potentially losing their reimbursement from CMS. And, at that point, I learned during the interview with Special Agent Ramona Smith that Miss Murphy and I were both actually from Bethpage, Tennessee, which is a very tiny area. I mean, there's a post office and a really, really crappy general store that smells like fried grease. It's tiny.
Like, really, what are the odds?
What are the odds? And that, I tried so hard during the course of that, because, I mean, I got called into the Tennessee Bureau of Investigation. That is not something you take lightly. I was nervous. I did not know what to expect. All I knew was that all of this stuff was all over Vanderbilt, all over the news, and they were at risk. And here I am in this Medicare fraud agent specialist office. We're talking, and I'm just trying to keep, professional and focused on answering her questions, providing the amount of information in detail. And then she drops this little bit of information on me, and I lost it. Because again, it was a step back to reality, right? You're in that code situation. You want to stay focused. And then you realize, this is someone and you're back to reality. You're back to being a human being again, and all those emotions.
Can't imagine.
So after that, oh God, I was really terrified, of leaving the house at all. It was 3 years later, I think it was sometime in spring of 2021, that I was in Tractor Supply, and I was buying some chicks, and a young man was helping me. And we just struck up a conversation about, an employee of theirs was moving to the area and, was looking for some land. And he had recommended that he look out in Bethpage, because prices were better and it was nice and quiet out there. And I made the remark, yeah, it is, cheaper than the other end of Sumner County, but it's not what it used to be. The land prices are really going up around here. And he was like, oh, you live in Bethpage? And I said, yeah, we talked about landmarks and roads. And I was like, this place, the road, the long road where there's basically nothing and a big field with an old tobacco barn and a bunch of sheep in the field. And he just kind of stopped. He said, yeah, I know exactly where that is. And he said, what's your name? And I told him my name is RaDonda. And he said, I know who you are. And I asked him, how do you know who I am? And his response was just Murphey.
And there it is.
And there it is.
And then how did it go after that?
Humbling.
Oh, I've got tears just thinking about that moment for you, RaDonda.
He was incredibly kind to me. I knew that it would only be a matter of time before I ran into someone in her family, given that we all lived in such close proximity. And he said the same thing to me. He said, I didn't know when or where. I knew I would run into you one day, and I didn't know how I would feel or what I would say. But I knew that at some point our paths would cross.
So what did he say? How'd that conversation go?
He told me that his family was a lot like his grandmother, that, they were upset naturally, that they'd taken a lot of time to grieve, but that she would have forgiven me. And he said, I'm a lot like my grandmother. I can't blame you for that. And was I upset and angry? Yeah. But, we've forgiven you. I've forgiven you for that. And he said, he told me that his grandmother had been really sick for a long time. And he described, the pain that she had, that she had been having a harder time, and that her health was not great, and her condition was hard for her. Life wasn't as good as it had been. She was in a lot of pain a lot of time, and that he could just be happy that she wasn't experiencing that anymore, that she was in a better place now.
Tell me what that meant to you to hear those words.
It's really hard to describe. He told me to take care of myself.
Bless his heart.
You do not know. You cannot imagine the amount of humbled that I was. That was probably one of the most profound moments in my life. Standing there in Tractor Supply in the middle of the store, crying like a child, with this young man telling me to just take care of myself. We've forgiven you. My grandmother wouldn't have wanted, she would have forgiven you. If my family saw you and you were on the side of the road, broke down, even if they knew who you were, they would still stop and help.
Wow.
it's a very gracious and kind thing, and it takes a lot out of a human to be able to lay yourself down and be that vulnerable and humbling to another human being when they've taken something from you that is so personal and valuable.
Yeah, the forgiveness is what kind of strikes me as overwhelming, and the compassion. Did it give you some, you've talked about how humbling it was. Was it healing for you as well?
Yeah. I actually still see him on a pretty regular basis. He doesn't work at Tractor Supply anymore. He works at the Farmers Co-op, and he will go out of his way to approach me, to say hi, to ask how my day is, to ask how things are going. And I'll do the same. We'll stay updated on, how the other one is doing and if life is going well or life is just lifing. Yeah. And I've had a chance to tell him over some of those interactions how incredibly grateful I've been for his presence and the interactions that I've had with him. That I'm grateful that I got the opportunity to meet him and to experience the person that he is, because people like that, I think, they're a rare breed, a really rare breed.
I bet he's grateful too. There's some healing on both sides there for that to happen.
I think so. I think it's safe to say so.
So it sounds like if this was 3 years-ish after the incident, this is before the trial. Am I right?
It was about a year before the trial. Mm-hmm. It was maybe a few months before the Board of Nursing hearing.
Oh, okay. Because it seemed like things had kind of calmed down, and I don't know if gone away, but maybe you felt right, that's dealt with. And then it seems like nearly a year later, there was, from what I've read, and please set us all straight on this, that there was a anonymous tip, a surprise inspection, a criminal indictment, federal investigation. How did it go from where you were on that day in Tractor Supply to trial? What happened there? Well, we're going to end this podcast right here as a part 1 of 2. I didn't intend for this to be a 2-part episode, but RaDonda and I talked for nearly 3 hours until the sun went down, until we both got tired, and until her very sleepy dog climbed right up into her lap to tell her it was time for bed. So check into part 2 because it picks up this story in October of 2018 after the Tennessee Nursing Board had completed their investigation, leaving RaDonda free from disciplinary action and her nursing license intact. I want to thank RaDonda for the very generous sharing of her story. I am so struck by her openness and her honesty about the events that happened on December 26, 2017. Don't miss this second episode. I feel like it is honestly one of the most important episodes I've ever recorded, and I am grateful to be able to share her story with you. Have a listen, tell all your friends and all your colleagues. And once again, RaDonda, thank you so very much. And a special thanks to all of you for listening in. If you enjoyed this podcast, please like and subscribe and leave us a review. And don't forget that in many jurisdictions, nurses, doctors, and lawyers can claim continuing education credit for listening. The podcast is, of course, available on all the usual platforms and on the Inside Medical Malpractice YouTube channel. For nurses in the U.S., you can listen and receive credit on CE Broker. After this couple of episodes, be sure to tune in as we then move on to tackle the tough and timely subject of infection control. Goodbye and take good care.